Hello, I'm Young Che. I'm a faculty at Northwestern University. I do biomarker development, early therapeutics, phase one, drug development, and clinical trial design. Today, we're going to talk about liquid biopsy in year 2021. These are my disclosures. We're going to talk about the concept of liquid biopsy and how it's going to be used in different indications. So the liquid biopsy is literally any liquid. It could be CSF, saliva, pleural fluid, ascites, stool, or urine, but mainly we'll be talking about peripheral blood. So obviously you don't do the tissue biopsy, so it's non-invasive. And here are the blocks that we use: circulating tumor DNA. It could be tumor DNA or non-tumor DNA. So in more comprehensive terminology, we say cell-free DNA. You could use germline or somatic. Circulating tumor RNA can be used as well, although its stability is not as good, but has more information. Methylation, open chromatin regions, when the chromatin, the DNA coils around chromatin, but when it opens, that's the area where the transcription happens. So DNA gets fragmented by enzymes, but measuring the size of fragments, it's called fragmentomics. So that information is reflective of the open chromosome regions and does convey what areas are currently functional. So it's a very important information to gather in blood. Exosomes, circulating tumor cells, proteins. The pattern of protein distribution, we call it proteomics. Or there's phosphoproteins, glycoproteins, so you can measure those. And of course, cytokines, hormones, and many other circulating molecules can be measured in liquid biopsy. So what are the main indications? Here you can see first, when there's a clinically undetectable tumor, you can use this for early detection of cancer, for screening. And if there's a clinically detectable tumor, then we can have the patient undergo surgical resection or even SBRT. Then you can use liquid biopsy to detect minimum residual disease. So we call it MRD detection. And then in metastatic disease setting, you use it for molecular profiling, therapy selection, response monitoring, and then at time of disease progression, you use it to identify resistant mechanism. T790M mutation in EGFR mutated lung cancer is a prime example. Subsequent therapy, you can use it to monitor clonal dynamics, which reflects the heterogeneity of tumor. So these are the main indications that we use liquid biopsy for. In my practice, I use it all the time to measure MRD, to select therapy based on molecular information, or to explore resistant mechanism upon any progression. Sometimes I do it along with tissue biopsy, usually at diagnosis or at progression. So this schema represents the change in clonal dynamics. Here you can see different clones are colored in different ways, and they change over time as different therapy selection pressures are applied. You see that the second line therapy, that the clones are changing. And the clonal burden also changes over time to a different level. So that's why you see mixed response when you change therapies. Here, we use liquid biopsy all the time in liquid malignancies like leukemia. So we measure minimum residual disease by doing PCR. But in solid tumor, the same notion gets applied. And now we are using MRD tests that are commercially available in our clinic. So I think one good example is lung cancer. We don't have PSA CA125 for lung cancer. So if we use liquid biopsy, mainly circulating tumor DNA, it will be a great opportunity to be able to do all the things that we discussed. And mainly in lung cancer, because it's a leading cause of death, and there are options, different treatment options available based on molecular profiling. And then also, we have such a high relapse rate after local control. So there's an opportunity to use MRD effectively. Now, also, there's many smokers, many lung nodules. So in conjunction with low-dose CT, liquid biopsy can be used to aid in better early detection of lung cancer. So MRD landscape can be seen as colorectal space and non-colorectal space. And many laboratories and commercial companies are going after colorectal cancer first, because usually it takes many years, up to 10 years for colorectal cancer to develop. It's the sequential carcinogenesis theory developed by Dr. Vogelstein. And here is a recent paper published in Clinical Cancer Research that showed that if you look at the cell-free DNA, as well as its methylation patterns, you can do a pretty good job in screening for colorectal cancers. After surgery, screening for relapse. So here is the performance of CEA on the left side. You can see CEA abnormal group doing worse in terms of survival. But in abnormal group, you can see that relapse rate is just a little bit higher than normal group. But if you use cell-free DNA, tumor DNA here, ctDNA detected after surgery group does a lot worse. And p-value is a lot smaller, with hazard ratio being 11 versus 1.8 with CEA. And as you can see, if ctDNA is detected, the specificity is about 100%. And sensitivity here is about 55%. So pretty good performance. In colorectal, so you can see, if you use genomics only, the sensitivity is about 40%. But if you use epigenetics, combine it with it, it goes up to 55. But in screening group, surveillance population, it's really high as 90%. So this is a performance also in non-small cell lung cancer and bladder cancer, also using the circulating tumor DNA. As you can see, integration of genomic and epigenomics is a lot higher in its sensitivity, and as the stage goes up, there's higher tumor burden associated with higher shedding rate, shedding dynamics. So you would be able to detect more ctDNA in the blood. So you'll see sensitivity going up as high as 83% for non-small cell stage 3, bladder 69% with muscle invasive type. And the ROC curves look pretty good. So currently there are many platforms out there. Guardant Health has a Reveal platform, and it's currently used for colorectal cancer. Natera has Signatera platform. It's currently used for colorectal cancer. In my clinic, I use it for lung cancer. And obviously there are more other laboratories that are developing and using the MRD liquid biopsies. To push gears and talking about early cancer detection, this is really talking about general population. Right now, FDA has approved 2 liquid biopsies. One is the Foundation liquid biopsy. The other is Guardant Health, Guardant 360 liquid biopsy. These are currently used to aid in cancer therapy selection and therapy response evaluation. However, none of them are designed to be used for early cancer detection. So there are tests that are being developed for this purpose. It is the holy grail in oncology. And we have different screening procedures like low dose CT for smokers, pap smear, colonoscopy. These are all screening procedures. But these blood tests are not meant to replace them, but they are there to assist or aid in improving the screening efficacy. So I listed some of them that I am familiar with, but they are not FDA approved yet, but they are CLIA certified, and some of them, like GRAIL, is also certified by the New York Laboratory Association. So GRAIL has Gallery. It's a ctDNA test. There's a typo here that are designed to detect 50 cancers, and they represent about 2/3 of all cancers. In fact, 70% of all cancers are not able to be screened by standard screening procedures. Luna 2 is developed by Guardant Health and is currently being developed specifically for colorectal cancer. Glory test is developed by Interven, and they use glycoproteomics using AI platform using the mass spec patterns. And they're aiming to use the panel for ovarian cancer early detection. Freenome has developed Preempt CRC, and it uses not just circulating tumor DNA, but any circulating DNA, cell-free DNA, as well as RNA, as well as protein. So it is called multi-omics panel. And this one, as you can see, is designed for colorectal cancer early detection. Johns Hopkins Group venture has published in 2018 in Science Journal, Cancer-Seq, and has pretty decent sensitivity and specificity, and it uses about 8 to 10 common cancer types, and also uses ctDNA and proteomics. And their prior version to Cancer-Seq is called Detecta, and there's been some publications. But in my mind, all of these are all just the selected versions of soon to be available commercial early detection assays, but they will require larger number of population study validation. So stay tuned. I'm just going to briefly touch on therapeutic indications. So I'll just briefly present a short case. So 46-year-old women, refractory cancer, EGFR exon 19 deletion, an FDA-approved test was the Roche EGFR mutation liquid biopsy test, and it was done in tissue as well as in blood. Patient first responded to afatinib, then progression. ctDNA test detected EGFR exon 19 deletion as well as T790M mutation. So what's interesting is the PCR assay was not able to detect T790M, but later, when the same tissue was sent to NGS panel platform, T790M was able to be found. So this is the progression we saw. And later, patient was switched to osimertinib after detecting T790M from plasma. There was slight progression, so Garden was repeated, and this is what you see. Very interestingly, RET fusion is detected as an acquired mutation and is part of the known resistant mechanism of osimertinib, along with PIK3CA mutation. So this is the progression we saw. And later on, when we repeated it, the clonal landscape changed, and consistent with that, patient experienced another progression. But later on, when we used RET inhibitor, patient did respond. Very unique, interesting case. This is a case that shows EGFR amplification when treated with osimertinib. As you can see, ctDNA is able to detect EGFR amplification, as you can see here. I do think ctDNA assays are like forensic medicine. You can actually see, just look at the mutations that are detected and wonder, while they've been exposed to different ALK inhibitors, leading to a few acquired resistant mutations. So you can sort of backtrack patient treatment history just by looking at new resistant clones. All right, these are different ctDNA assays: allele-specific, PCR, emulsion, PCR, amplicon-based, capture-based DNA, targeted NGSs. So if you use NGS-based ctDNA assay, you'll be able to detect all these indel, fusion, CMV, copy number changes, SMVs, but really, really low false positive rates. And can detect multiple different types of mutations at the same time. This is a BRAF case, and this is my own patient case that shows different type of BRAF mutations that are detected by the ctDNA NGS. And this is what happens when the therapy works very well. All these clones becomes undetectable after, in this case, for BRAF targeted therapy, the dabrafenib trametinib combo. And this is sort of the somatic allele frequency changes that we saw over time. This patient is still doing well after 4 years of targeted therapy. So one of the things we can detect is with good favorable ctDNA change, you could sort of differentiate real progressors from pseudo progressors. And that's $1 million questions. But using ctDNA dynamics, you can say this increase in size could be the lymphocyte infiltration, not true progression. And if you have favorable ctDNA change, they do always better. And the other value of ctDNA analysis is to have phylogenetic analysis done. This is actually done in autopsy patients. And you can draw pre-surgery and at relapse phylogenetic tree of the different clones. This way you'll know which clones are new, which clones came in as a resistant clone. And they correlate with stage, necrosis, volume, and so forth. And then if you can, you look at the left side upper graph and say, wow, as the tumor volume gets larger, the mean clonal plasma variant allele frequency goes up. And these are a linear trend. And this is the minimum residual disease paper in lung cancer that after local therapy, if you detect ctDNA, most of them show progression, while if ctDNA is cleared after radiation or surgery, they do not relapse. So very different stark contrast between two groups in terms of survival. So real world question is liquid biopsy better than tissue biopsy? So I think the question is wrong. The difference in biology, it will always be there. It's not that one is better or the other. So I looked at the concordance between the two using NGS, and this is number of alterations using different tissue or blood biopsy. And these are number of patients showing different mutations. And as you can see here, the concordance lies somewhere between 10 and 17%, depending on what panel and what group you look at. But remember, you don't look at concordance patient-based, you look at it mutation-based. So amazingly low, it's about 10 to 20%. But if you look at like individual genes, the concordance could be as high as 90%. If you only look at one gene, but if you look at all the genes that are detected, the concordance goes down. And I looked at the same pattern among breast cancer patients. And as you can see, green is the only mutation variants that were detected by both tissue and blood. So concordance does matter if ctDNA is present, then it's likely real. If it's not present, we really don't know. It may simply just not be shedding. So really, there is no gold standard. There's only technical variance and difference in biology. And I believe liquid, because it's going to collect all the ctDNA that are shed from different sites of metastasis, it has potential to better reflect tumor heterogeneity and also potential for metastasis aggressiveness. So I believe combining tissue and liquid biopsy data will give us a better idea of heterogeneity and clonal dynamics. So I want to emphasize that in liquid biopsy, very, very low allele frequency sometimes will still be very meaningful in terms of selecting therapy. As low as 0.06% VAF ALK fusion have shown very good response to crizotinib, as you can see in this case example. So don't let low VAF fool you into, oh, this is just a minor clone. This clone will not respond. No. So I think the future should be focused on coming up with the best treatment algorithm. An RL trial, which led to companion liquid biopsy of EGFR ctDNA assay. And what I'm trying to show you is whether you use tissue T790M or plasma T790M, the waterfall plot looks pretty similar with pretty similar overall response rate. So this is a proposed algorithm for treatment for EGFR cancer. And really, for detectable ctDNA after definitive treatment, what do we have to do? We need to come up with a guideline. And if it's non-detectable, should we skip adjuvant chemotherapy? That's $1 million question. And that requires clinical trial to validate that concept. But it's something that government has to do, not pharmaceutical company who are interested in escalating care than de-escalating care. So there are many remaining questions. What's the best platform? We need to compare different panels. And if molecular profiling is done, what's the best matching therapy? And so forth. So really the take-home message is liquid biopsy, mainly ctDNA tests, are currently ready for prime time. It's being used. I use it all the time in my clinic. Detection of actionable target and resistant mutation is the key at the moment. Detection of MRD is of clinical significance and is currently being used in clinic. There are commercially available panels now being in use. This will come as a near future in solid tumors. No, it's now being used, and colorectal cancer is the first one. Lung will follow very soon. Clinic Azure Lab, we learn as we move forward, stay up to date on precision medicine, because even though we detect a certain mutation, if you don't know what to do about it, then it's no use. I think we need to develop an algorithm with this mutation. What do we use as a therapy, intervention, and so forth. And also early detection space. It's still very exciting. I think the panels will be FDA approved very soon. And I think these will revolutionize oncology as a field very soon. So stay tuned for more updates in the field. Very exciting. Liquid biopsy will continue to dominate the field. So thank you for listening, and I'm happy to take questions during our discussion time. Thank you.